morning, everyone. Welcome to the League of Women Voters of Kitsap's Public Education Forum titled End of Life and Reproductive Healthcare Services, What's Available in Kitsap County. My name is Jessica Guidry, and I am one of the co-chairs of our League's Healthcare Committee. Our other co-chair, Lenny Scrin, is going to be taking care of our technology. We have a full agenda ahead, so we'll go ahead and get started.
Hi, this is Lenny, and I'm going to ask everybody to just wait a couple of minutes. We have 67 people signed up, and right now we have about half of them trickling in, or no, more than half now. So give it maybe just one more minute, and then go ahead, Jessica.
Okay.
All right, Jessica, please begin.
Okay, so I'll go ahead and I'll start from the beginning. So welcome everyone to our End of Life and Reproductive Healthcare Services Public Education Forum with a focus on what's available in Kitsap County. My name is Jessica Guidry, and I am one of the co-chairs of the League of Women Voters of Kitsap's Healthcare Committee. And our other co-chair is Lenny Scrin, who's going to be taking care of our technology. Before we get started with our program, I want to share a couple of things about the League of Women Voters. The League of Women Voters was founded over 100 years ago in the days of the women's suffrage movement. The League of Women Voters is of Kitsap, is one of 21 local leagues in the state of Washington. We envision a democracy where everyone has the desire, the right, the knowledge, and the confidence to participate. We are nonpartisan, but always working on vital issues of concern to members of the public. The League welcomes people of all genders who are 16 years or older to join us. As part of our mission to empower voters and defend democracy, we hold free public education events on a wide variety of topics. In the last few years, we have hosted many education events of local interest, such as on issues on climate change in your health and how redistricting works in Kitsap County. Recordings of all our programs are available on our website, lwv-kitsap.org. So some notes about how this webinar is going to be conducted. This is a Zoom webinar, not a Zoom meeting. So all participants are muted, and we can't see your faces as well. I believe some of you may see a raise hand feature. We're not going to be monitoring that. So if you do have questions, please place them in the Q&A, and you should be able to see the Q&A at the bottom. The way that this education forum is organized is we're going to hear 4 presentations, and then we'll have Q&A, and then we'll look at the questions of the Q&A and ask them of our presenters. This webinar is recorded, and the recording will be put on our website in addition to a handout with some informational resources as well. So with that, I'm going to quickly introduce our moderator, Dr. Gib Morrow. Dr. Gib Morrow has served as the Kitsap Public Health District Health Officer since August 1st, 2020. Previously, Dr. Morrow served as the Deputy Health Officer in Whatcom County, Deputy Health Officer in Sonoma County, California, and was a primary care internist and hospitalist for over 20 years at Peace Health St. Joseph Medical Center. Dr. Morrow has served in a variety of leadership roles, including Internal Medicine Department Chair, Board Director, and Secretary of a large independent multi-specialty group, Medical Director for the Whatcom County Jail, and co-founder of Whatcom Ducks, a coalition of over 200 physicians whose purpose was to evaluate and communicate the health and economic impacts of a proposed coal export facility at a deepwater port in Whatcom County. Dr. Morrow received his medical degree from Duke University School of Medicine and completed his internal medicine residency and his master's in public health at the University of Washington. So to go ahead and invite Dr. Morrow.
Well, thank you, Jessica, and welcome to the League of Women Voters discussion on end-of-life and reproductive health care services available in Kitsap County. I do want to thank Jessica and Lenny Scarron for the opportunity to moderate this discussion, as well as the opportunity to introduce our speakers. Looking forward to hearing from them, and really thank you to all of you for your interest and your attendance at today's event. These are important and timely topics. Late life and reproductive health delivery systems are critical to meeting the quadruple aim of healthcare. And this is the elusive holy grail, which is defined by improved population health outcomes at reduced cost and with improved satisfaction and experience of both patients and providers. These are really all critical to our healthcare delivery system and to our overall health outcomes. So we all know that late life and reproductive health issues don't exist exclusively in the realm of healthcare. Our educational, our legal, our legislative, our economic, and our cultural sectors all considerably impact choices, access, cost, and outcomes for both reproductive and end-of-life health issues. For example, 35 states have recently introduced over 137 bills limiting what schools can teach with regard to race, American history, politics, sexual orientation, health, and gender identity issues. Just Monday, 2 days ago, Idaho passed legislation modeled on the new Texas law prohibiting abortions after about 6 weeks of gestation and allowing family members of a, quote, preborn child to sue abortion providers. On the flip side of the spectrum, oral medications are safe and effective ways to end an early pregnancy, and many advocate that these should be available over the counter. Both Washington and Oregon passed death with dignity laws over a decade ago. These laws allow terminally ill adults seeking to end their life to request and receive lethal doses of medication from physicians. About 1,500 or so Washington residents chose this option in the first 9 or 10 years of that law. While this law applies to relatively few people, essentially all adults should engage in advanced care planning efforts. This is ideally a long-term process that's best started in early adulthood and revisited frequently over the course of a person's life, with the goals being to identify surrogate decision makers for health issues with whom to have ongoing discussions of the types of treatment and level of care a person will want to receive under conditions of declining health status, acute severe health issues, or progressive cognitive decline. And these are fates that are in all likelihood going to impact essentially all of us. In the absence of effective advanced care planning, our default approach in our current healthcare system to failing health at end of life far too often is that do everything approach, even when these often expensive efforts are non-beneficial, inappropriate, or unwanted. So these are both really complex and, of course, per usual, controversial topics. And we brought in a panel of local experts. It's my pleasure to introduce them. And I will start off with our first speaker. Betty Herman is a volunteer at End of Life Washington. And for the last 7 years, Betty has considered herself privileged to be a volunteer with that organization. This is the organization that supports patients who want to use Washington's Death with Dignity, also known as the Medical Aid in Dying Law. She educates the public about the law and works to both preserve the current law and advocate for revisions that will make the law more accessible. Betty Herman is owner of Elder Resources LLC, where she supports seniors and their families through life transitions and does estate administration. She mentors other care coordinators to groom them for taking on new clients as our Kitsap County population ages. And with that, I will turn it over to Betty, who will speak for about 10 minutes or so, and then we'll pass it on, and I will introduce subsequent speakers and ask questions. So Betty, over to you.
Well, greetings to all of you. I hope that this becomes educational to you, and know that I'll always be available as a resource. My phone number will be up on the screen in just a moment. As you listen to this information, please remember that discussing end-of-life issues is personal as well as political. I understand that the League is more focused on political, but I work with clients who have planned ahead for more than a year, those who have died before they could get through the 18-day process from first oral request to end their life in a dignified and humane manner to actually ingesting the medications, and the many iterations of decision-making in between these 2 points of reference. Please hold in your heart the individuals who are affected by this information. I will do my best to share my screen now, assuming that, there we go. Share screen. Good. So let me start my timer. So I'm very pleased to be here, and I've been asked to share with you how End of Life Washington helps the residents of Kitsap County, as well as across the entire state. And we also cooperate with folks from other states. We work closely with the people in California in particular to help them, and they help us with tracking current information. So with our education and resources, one of the things that is most popular and most effective is our End of Life Ready program, and it's an introduction to advanced planning and ending and end of life options. The next session that is available to the public is March 23rd from 5:30 to 6:30 p.m. If you go to endoflifewashington.org, you can certainly click on that and get those details. The other things that are available there is the advanced planning, choosing your healthcare agent. And I want to strive to have you understand that choosing your healthcare agent is so important. And I'll just tell you from my own family, I am my niece's healthcare agent. She's an adult, she's married, she has an adult child, she has parents that are still living, and she does not believe that any of those other folks would help her at the end of her life if she needed it, that it would be too painful for them. So she's elected for me to make those decisions for her. In making those decisions, and on the End of Life website, there's something called the value statement. And it's a list of about 20 questions that give you the opportunity to say, this is what's important to me, and this is what's less important to me. My religious beliefs are most important to me, or they're less important to me. My pain management is more important or less important than my cognitive ability or the ability to relate to my family. So I really strongly encourage people to look at that. There are so many more resources. The support looks like a volunteer client advisors such as myself. I work throughout Kitsap County. There are only 2 of us who reside in Kitsap County who are playing this role of assisting people through the entire process of either finding doctors or and all the way through taking their medication. Often they're mixing the final medications for people, helping the family as we're waiting for someone to have their heart stop. So there are only 2 of us. We need more volunteers. Please consider this. We keep the clients on track as they're going through the process, and we support families and encourage doctors to make appropriate medications for someone who is choosing to voluntarily stop eating and drinking, which is another choice that's available. There are only a few doctors who are in Kitsap County who actually will prescribe. There are some who will consult but not prescribe, because you do need 2 doctors to certify a variety of things before you're eligible to have life-ending medications. There are no pharmacies in Kitsap County that will compound the medications. We had one in Paulsbo and they opted out. So we work with pharmacies on prices. We work with pharmacies on deliveries and have very good relationships with the 2 pharmacies that are closest to Kitsap. There's paperwork that the clients have to fill out. So there are 2 oral requests and 1 written request, and we help them with getting documents in order for the physicians. And then after someone has passed, there's paperwork that the doctor has to put in to the state. And so we help the doctors through that. We coordinate with hospice very closely. 90% of those folks who use medications have had hospice support, and 91% have been able to die at home, specifically because of hospice. Because we have only a limited number of doctors, we really nurture those relationships. All 4 hospices that provide service in Kitsap County have limited resources right now. So it's just pretty overwhelming from COVID as well as other issues. So what's legal is medical aid in dying, also known as death with dignity, and that's using the actual medications versus voluntarily stopping eating and drinking. The using of the compounding drugs, and End of Life Washington works very hard with practitioners to refine the formulas so that the passing is smooth and easy, and then supporting folks with voluntarily stopping, ending eating and drinking. And that's a process that takes a fair amount of management by family. People can go through some disorientation, and it takes usually a couple of weeks versus using the medication, which takes several hours. We also work politically in the larger realm. We worked hard on House Bill 1141, which did not get out of committee, but it works on shortening the waiting time so that 18 days isn't so onerous, because a lot of people wait till the very end to make this very difficult decision. It widens the scope of qualified providers so that more folks like physician's assistants could write the pill, the prescription, sorry. And it also modernizes prescription delivery services. It didn't get out of committee last year or this year, for a combination of reasons. We can tell the stories, we can give the statistics, we being End of Life Washington, and then many passionate religious organizations and individuals are our counterpart. And so it becomes an issue of whether or not this is high enough priority, both for the politicians to take a stand and for the full legislatures to spend their time. Thank you so much for listening. I have only a minute left. So let me tell you that some of the doctors that are not associated with End of Life Washington are giving out incorrect information, or they don't understand the Death with Dignity law. Many of these folks that are having that issue are new to Washington State and have come from other states that do not have this. Some doctors are reluctant to participate, but don't actually specifically state that. And so their patients are in limbo for a while. So those are the most salient points that I can come up with. Dr. Morrow.
Thank you very much, Betty. It's really informative and will help frame some of the additional discussion going forward. And at this point, I'd like to go ahead and introduce Alexa Brenner. Alexa is the Planned Parenthood Alliance Advocates Regional Field Organizer for the South Sound and for the Olympic Peninsula. A near lifelong resident of Pierce County, Alexa grew up in Gig Harbor and currently resides in Tacoma. Her proudest moment in her time at Planned Parenthood was last legislative session when the Protecting Pregnant Patients Act passed. Nice alliteration there. And she hopes progressive and positive legislation will continue being championed at the legislature for many years to come. And with that, I will turn it over to Alexa. Her list of questions is in the agenda, and let's hear what you have to say, Alexa. Thanks for.
Yay, hello everyone. I have to amend my proudest moment because Washington, the legislature just passed a proactive abortion bill that I'll talk about in a little bit, which is really exciting and we really love it. So I have some healthcare questions that I'm able to answer, happy to answer, and then also just going to give you all a little bit of a rundown of like what's going on politically and legislatively. For those of you who don't know what a regional field organizer does, I wear a lot of hats. Sometimes they look like bows, but I wear a lot of hats, and I work with our lobbyist, and we talked to the legislature about passing really great legislation and defending against really bad legislation about reproductive health care. A lot of you have probably heard of the sex ed legislation from 2020 that went on to be R90, the ballot initiative about sex ed in schools. That Planned Parenthood did a lot of work on that, and we sit in coalitions and do other things that focus on reproductive health care because we are a reproductive health care organization. So the first question being reproductive health services that are legal in our state. Abortion is legal in Washington. We have affirmed this this session, so awesome. We also, with the passing of the Affirm Washington Abortion Access Act, we call it AWA. There's lots of A's there. Again, with the alliteration, we just really rock it. We passed, or this legislation was passed, also decriminalizing is technically the word, basically making it so pregnancy outcomes cannot be criminalized. So we've heard of other states, there have been issues with patients having a miscarriage and being arrested or sent to jail, or any pregnancy outcome cannot be criminalized. And people who help their family members, their friends access reproductive care, whether that be abortion care, miscarriage management, cannot be prosecuted in Washington state. So protecting not only a pregnant patient, but also protecting the people in their life who help them seek the care that they desire. You know, there's no, I'm sure you've all, or at least those of you in the 26th have heard the name Jesse Young before. He is the, you know, the villain in a lot of this, in the sense of he tried to pass tried to introduce a 15-week abortion ban in our state legislature, wasn't even heard in committee. So we as a state right now have a reproductive health, pro-reproductive health majority, which is awesome and stuff we need to, you know, work really hard to keep. Because it allows us to do things like continue to be able to provide abortions in our state. The Bremerton office specifically provides the full range of our reproductive health services. So birth control, STI and STD screening, any sort of family planning style visit, gender affirming healthcare. We also provide in-clinic abortion services and medication abortion services. Different appointments, but we have, you know, there's in-clinic abortion days. Oftentimes that's when you'll see protesters outside of our clinics. And we just have the one office in Bremerton on Rydell Road. So that is our one clinic in Kitsap. And it is also a clinic where we have patients from Port Angeles will have to come if they need an in-clinic abortion service, or our Shelton patients will come if they need, prior to Shelton closing, they would come for in-clinic abortion services, but also now we see a lot of our patients from Shelton there regularly because we no longer have the Shelton clinic. During COVID, we saw an 18% decrease in patient volumes overall. And so not only is that worrying in the sense that people aren't coming for their PAPs and their regular STI screenings and birth control appointments, so they're not checking in with a provider to make sure their general reproductive health is great and they're doing okay, and you know there aren't any issues that we're not catching, but also like truly transparently financially that's really hard on our clinic, with Title X funding being still not restored because of the lawsuits that are going on in Ohio that are misogynistic and racist and just really bad for people who need safety net abortion providers like Planned Parenthood. We just haven't seen the full restoration of our funding. So it's rough and it's hard, but we're not going anywhere because we are that safety net for a lot of patients who are on state Medicaid, who can't be seen by providers at other organizations, or who aren't able to be seen because there are providers that just don't take Medicaid because of the way that reimbursement rates work. Access to reproductive services in Kitsap County, it's you know more than I do about just the way that Kitsap County is really concentrated around Bremerton. So those who are in Bremerton, obviously it's a little easier for them to get to a clinic, whereas people who are driving from further out they have to think about how are they going to get there for whether it's an abortion or a birth control visit or an IUD insertion, whatever they may be going for. You know, how do I get there if there's no public transit, if I don't have a reliable car, if I don't have childcare? There are so many different pieces to think about when accessing reproductive health care, especially now during COVID. I mean, prior we didn't, obviously, in the health centers, it's not a great idea to bring a small child with you when you're having an IUD inserted. For those of you who have had one inserted, it's not the most comfortable experience, but also it just, we can't bring extra people into the health centers right now because of COVID. So we're really just working kind of against all of these extra factors. We're not going anywhere. The Bremerton Clinic is still open and still serving, the people of Kitsap and also counties beyond. But we also, it's not just right now, it's not just the health services that we provide. we a lot of people are dancing around the Supreme Court, the things that are coming up, and the Supreme Court decision that'll be out towards the end of June. And Roe is going away. And that is not a pessimistic view. That is what will happen. And when Roe goes away, abortion will become illegal in 26 states. Washington will see a 385% increase in patient volumes for abortion services. Dr. Morrow mentioned that Idaho just passed an abortion ban, a Texas-style abortion ban. Planned Parenthood was 2 of the 3 abortion providers in the state of Idaho. There was another OBGYN in the northern part of the state that would provide them, but they were already so strapped for access and so strapped for people to provide abortion services. And we are going to start seeing, as soon as the governor signs this bill, it's a 30-day moratorium. We're going to start seeing patients from Idaho. Our health centers are seeing patients from Texas already. The believability gap of abortion being on the line is so less than 1/3 of people in this country believe that abortion is on the line. So it's really about showing up and being involved, especially at 3rd down ballot races. I mean, we all love Emily Randall. She's amazing. And her seat's at risk. There are no safe seats this year. And so we showing up and allowing her to be awesome while we come in and talk about how important it is to keep a pro-choice majority in our state legislature is what is keeping Washington a safe state. I'm looking at the clock and it looks like my time is up, so I am done. I will pass it back to you, Dr. Morrow, and thank you.
Thank you so much, Alexa. And it will be really interesting to hear specifically which services are offered by different organizations with respect to reproductive rights. There's been a lot of lack of clarity about that. Some services advertise as being available for reproductive health services, and they primarily offer counseling and referrals for adoption and other services. There was an interesting Washington law, I guess it was 5602, which required hospitals and other health systems to really be more specific about the exact services that they offer. So we'll hear more about that in a moment. I just do want to remind members of the audience that now's a good time to start popping questions into the question and answer box there. We would love to hear what you want to know. We did receive a number of questions in advance, and so we have some handy, but if there are any burning questions, get them out there and we will be sure to ask our panelists here at the conclusion of this. So our next speaker is Dr. Leslie Waldman. I've had the pleasure of working with her on a few occasions and really appreciate your participation and involvement. Dr. Waldman is the Associate Program Director of the Northwest Washington Family Medicine Residency Program right here in Kitsap. And as a provider at the CHI Franciscan Family Medicine Clinic, which is part of the VM Franciscan Health System, Dr. Waldman provides full spectrum family medicine along with advanced surgical obstetrics. She counts being part of the birth of a child as one of the most memorable and amazing aspects of her job, and absolutely what's more memorable and important than that service. She also enjoys caring for those who have navigated their family through this world and are now enjoying retirement and approaching late life health issues. Dr. Waldman earned her medical degree from Georgetown University School of Medicine. And with that, I will turn it over to Dr. Leslie.
Awesome. Thank you so much. I am just going to take a moment to see if I can share my screen correctly. I practiced, everyone. I hope it's right. Thank you so much for inviting me today. I think this is an amazing topic. It is a little daunting to hear at the early parts, Gib saying I'm an expert. I would say I enjoy this part of medicine, both reproductive healthcare and end-of-life services, but I did talk to and get input from a lot of my colleagues within the system to create this slideshow today. And so the names would be too long, but just a shout out to all of those people that helped this and make sure that you guys are getting really important information that's correct. So just starting out, people wanted to know, where are we providing comprehensive reproductive health care? And so I highlighted those clinics for you guys here. And then I just wanted to spend a little more time focusing on a few specific ones, and that is my clinic, which within the Virginia Mason Clinic is the only one that is providing prenatal care. We do not have OBGYNs in our staff at Virginia Mason, and we are lucky to have a plethora of great OBGYNs in the community. And so, and then we do have an affiliation with the doctor's clinic, but they are not part of Virginia Mason on the outpatient aspect of it. And then one of our clinics, and I'm going to talk a little more about what is comprehensive reproductive health care. One of them is just internal medicine. So that clinic in Poulsbo, just a little bit more limited spectrum on what they provide in regards to comprehensive reproductive health care. There's always questions on the numbers game, and they were a little daunting what people asked. So how many people do we care for in regards to reproductive health? And that's an almost impossible question, just because in the outpatient sector, we don't keep those numbers. So I thought I would at least give you something that might be helpful. And that is the numbers of patients that we delivered at St. Michael's over the last year, so that you could kind of see. And then I just gave you a comparison of other local hospitals that are part of the system. And so last year we delivered 1,863 patients. So I'm sorry, this is our fiscal year. So you can see the numbers are from July to June. And so I just thought that might give you at least some ballpark idea of what we're thinking about. And again, not all of those patients are cared for at our clinics on the outpatient basis, but I thought that might be helpful for you. So when I say comprehensive reproductive health care, what does that mean? And I think that specific question that you're going to ask me is, what does that mean at our Virginia Mason Franciscan Health Outpatient Clinic? So I think of it as extremely broad. And I highlighted maybe words that people care about of what happens at our clinics. But at my clinic specifically, we provide family planning counseling and all contraceptive options that are available. I do tubules, etc. All cancer screenings that we need, or referrals for mammograms. We give all immunizations, including HPV. I actually, if you just want to flip the side a little, we do vasectomies in our own clinics there in Bremerton. And I think the other ones, which and also we care for our gender diverse persons, including prescribing hormones within our clinic. And so it's a comprehensive goal, and it's important for me because I'm training our youngest population of doctors to join our community. And so we want them to be trained in every aspect of care. Just pinpointing, I think the question that came through a little bit is when it comes to situations like emergency contraception, what do we provide? And I would say we certainly talk to all of our patients about every option available to them and support them in these difficult times. We absolutely provide emergency contraception prescriptions, although you can get them over the counter. I do, of course, I'm a teacher, so I always like to give one teaching point during my presentations. But in the sense of this one, emergency contraceptive pills just stop a woman from ovulating if she happened to be planned to do that during that time. It doesn't actually end a pregnancy. So those prescriptions we prescribe. One of the things you can put in, which is an IUD, and that would end a pregnancy. And so for us, I put in IUDs, but my goal in our clinic is for prevention of pregnancy. So we don't put them in with the intention to end a pregnancy. And so we have a pleasure to have good working relationships with other colleagues that are joining me here today. And so we get them to the right places of the people that can give them the services they want and need. And so we would make a referral to Planned Parenthood for both of those situations. You would think as a family physician, it's easy for me to transition quickly to end of life, but honestly, this still feels really awkward. So I just threw a slide in there so that we could all turn our brains around and say, all right, so that's kind of our reproductive side. And so what happens when we are born our retirement times and we're navigating our healthcare needs at the end of life? So Virginia Mason Franciscan Health, we have 2 types of care that are available near the end of life. These teams work in our hospitals. They go to our patients' homes, and then there is a Franciscan inpatient hospice house and University Place that sometimes patients will be. I really appreciated the question about information available on our website. I actually looked all around, and I would say that it's not clear to patients if you were to look on our website. And so as we were all talking about information that physicians give, most of the information that is provided to our patients is through the providers. And you're right, I know it was talked about earlier, is not every provider might have all the information that everyone needs. And so that is an ongoing thing that we're working towards. Both in the palliative care, where we're helping patients at any stage of their disease process that's ongoing to make their symptoms better and achieve their goals, versus hospice care. And those, we generally see around 6,000 patients a year. That was kind of a question for us. And then there's that other we are considered a non-Catholic hospital. So that is, I know some people use the terms secular, non-secular, but it was very clear to me in talking with our communications person, we use Catholic and non-Catholic. So St. Michael's is a non-Catholic. It doesn't mean both for the abortion idea or termination idea earlier, or with, thank you, Betty, for the helping patients navigate death with dignity. It is very limited on what we provide in those situations. Our goal is to counsel our patients and help them along to get to the right people that provide that care. And so for instance, for us, if a patient meets the needs, so they would qualify for the Death with Dignity Act, they have to give us requests a couple weeks apart. We will accept those requests. They have to be in writing. And we are fine being one of 2 qualified healthcare providers to sign off on they meet all of the requirements. And so we can participate in that aspect to, again, help our patients get the needs that they want. And so I feel very comfortable that we're a part of that. Our Virginia Mason providers, and if not during work, but they want to participate with Death with Dignity, they want to work at Planned Parenthood, we are always welcome to do that outside of our regular hours also. And so I think just trying to understand that part of it might help people, and seeing where, yes, we should always be checking and making sure that people in our community can get the healthcare that they need and is important to them. And so I kind of covered that. I kept it hopefully pretty short for you, Jessica, because that's all I had. And hopefully I answered those questions that you guys sent me.
Thank you so much, Dr. Waldman. And you absolutely will be getting some questions directed to you, I'm sure, momentarily. And thank you for your wonderful presentation. And with that, I'm going to turn it over to Dr. Regina Bonnievie Rogers. Dr. Bonnievie Rogers is the Medical Director of Peninsula Community Health Services, PCHS. That's the only federally qualified health center in Kitsap County. We are so grateful to have their collaboration and services here. We are very fortunate to have them as really a Kitsap specific, Kitsap Plus specific organization. She started out at PCHS as an internal medicine provider at the 6th Street Clinic in 1998. She's known for her dedication to improving health outcomes and removing barriers to care for all PCHS patients. And Dr. Bonnievie Rogers is a strong advocate for diabetes management and integrated behavioral health services. She earned her Bachelor of Science in Liberal Arts from Evergreen State College down in Olympia, and her medical degree from George Washington University School of Medicine. So we've got a couple DC area med school graduates. And with that, I will turn it over to Dr. Regina Bonnievie.
I think I'm unmuted, correct? Okay, great. It's a pleasure to kind of introduce our services regarding family reproductive care, as well as end of life services that we provide. Great. I'm going to try to share my thing here. It's done, so I'm going to be there. Can you see my slideshow?
Not yet.
Okay. Must to do it again. It's just under the share, right? Share. There it is. Share. Done?
Yes.
Excellent. Wow. I was all nervous that wasn't going to happen. And then I need to start from the beginning. Where is that? Let me get this smaller so I can start slideshow from the beginning. There you go. All good? Excellent. So I've been, as you know, been at Peninsula Community Health Services since almost 23 years, and we've grown immensely. As Dr. Morrow said, we are the only federally qualified community health center in Kitsap County. Our mission is there, exemplifies the culture of community service, and our vision is to eliminate healthcare disparities in our communities. And our core values is patient-driven, empathetic, staff-empowered, and our guiding principle is to see and value every person. This is where we all start in all our clinics. The history is there. We started off in the 80s as a local physician dental information referral project, and then became a full-fledged federally qualified community health center in 1993. In 2013, we were accredited with AAHC for being a patient-centered medical home. This is our various location. As you can tell, we have grown. We're all the way up in Kingston, Poulsbo, Silverdale, Bremerton, Port Orchard, and all the way down to Shelton. And we just opened a new clinic this year at Key Peninsula. This is the kind of the fixed clinics, but then we have a ton of mobile services as well as school-based clinics. We also have providers in the emergency room to facilitate transition of care. We are a jail and several of our behavioral health partners. We're also helps out at the Washington Youth Academy. The question is how many patients we've served in the last year. Over 35,000 patients in our community. And there's the age range. A majority are the adults between 18 to 64. We are the kind of the network that takes care of any patient that has no other providers, but we take all comers. If you need something from a primary care perspective, we will see you, and this is our insurance. We have 10% are uninsured. Majority are Medicaid, Medicare patients. Our services is vast, as I don't want to belabor it, but I think I want to make sure to underline wellness and preventive care. We have reproductive and family planning services. In fact, we're one of the state-granted family planning service providers. We just started an OB/GYN program. We have 3 obstetric gynecologists that are in our Port Orchard and Silverdale clinics that assist with deliveries and any gynecologic problems. And we utilize St. Michael Hospital for those. We do every other care. We have a very intensive behavioral health program. We treat mental health as well as substance use disorder issues. Here's our mobile clinics. So during COVID, the last 2 years, we have utilized these outreach vans to do testing as well as vaccine, and to meet and to go to people who can't come into the clinic or have transportation issues. So we have been going to homes and neighborhoods to just facilitate the care that's needed during this very kind of challenging times. Our other services, we do interpretation as an FQHC. We have to provide translation services. As you saw, all the mobile, we have a lot of transportation. We also provide for some people. We provide some insurance navigation, and we're very involved in meeting the social determinants of health. And we do some screening, and we have resources. We provide like a bag of food for some patients who identify that need. We have low-cost pharmacy. We have helped with infant toddler supplies, as well as provide some housing and rental resources. We have a ton of providers, over 35, 40 providers in all the clinics. including behavioral health. We have psychiatrists, counselors, dental also is in our system, as well as five pharmacists that does prescription dispensing for our patients only. And in terms of reproductive health, as I said, we are one of the granted family planning providers here. We do family planning questionnaire yearly to say do you have intention to get pregnant, and then we counsel as needed. We provide all contraceptive management options. We counsel a pregnancy option, and then if needed, we refer to Planned Parenthood for all the options that's needed. We do the delivery, obstetric, gynecology service, and we do all the preventive wellness care for women, and in terms of PAP, mammogram, bone density, you name it, we do it as primary care. End of life care, we do medical wellness visit. As an internist, I see a majority Medicare patient. I was just celebrated one of my patients' 100-year birthday recently, and it was wonderful. I just love older people. And then advanced directive counseling, we do this yearly as part of our clinical measure we're really proud of. We have some conversation about their wishes in the future, and we really collaborate with St. Michael and other kind of hospice and palliative care programs that we do referrals. I think those are the main questions I had. Anything else?
We'll have some more for you momentarily.
Okay,
Absolutely.
all right, I will
Thank you.
unshare, or you can take that over, the sharing. I will stop
You
sharing.
can just stop sharing up at the top, I think. And
All
thank
right.
you. And I just as the Kitsap health officer and working through these last 2 years of pandemic response, I really do want to thank specifically both Peninsula Community Health Services as well as the Family Medicine Residency Program. They've really engaged in these efforts. Both groups have been innovative and proactive, and really wonderful collaborating partners in every inch of this crazy last couple of years. So thanks to both of you very specifically for your work in that regard. So we do have a number of questions in the chat box, and I guess what I'll do is start off with one that I guess would be directed primarily to Drs. Waldman, Bonnievie, Rogers, and Alexa as well. And the question is, do your clinics in the hospital have rape kits? And could you educate us a little bit about what happens in that event? Are there specific certified providers involved in those events? Where do those evaluations happen? If somebody who has been raped goes to the emergency department at VM Franciscan or to one of your clinics, do they routinely get referred for abortion or morning after pills? What does that whole process look like? And maybe Dr. Waldman, I'll put you on the spot first, and then over to Dr. Bonnievie Rogers.
Sure. So St. Michael's uses the amazing SANE program. So we have a sexual assault nurse examiner who's available 24/7 for the ER centers. And so if someone comes in with that, the nurse on call is called in to help, who is trained in the etiquette and helping these patients through it rather than our ER providers necessarily. And they see them, they can arrange for any urgent or emergent outpatient clinic needs that they need for treatment. At that visit in the ER, they could prescribe the morning after pill if needed. The charts are signed by our ER colleagues, a couple specifically, and so they have the ability to treat emergent needs and then get close follow-up. And sometimes even if a patient is farther outside of the window of a, immediate treatment, which is sort of past 5 days is the common thing, so they don't need those sensitive exams or being offered them, they will help them navigate and make sure that they get to the providers that they need. They are offered the examinations there. We have the kits there, and they talk them through all the information about doing the exam or not, and then they would be able to take care of it there. And I just think it's a great program because these nurses are just literally trained in that area. And so I think it provides the best care for the patient. But we would be able to meet what I think is all of their needs in a very timely fashion.
Thank you. And,
yes.
and do you know if they're routinely offered or provided prescriptions for mifepristone or misoprostol? You may have mentioned that, but
no, that would help us navigate. They would be navigated to our colleagues with Planned Parenthood. We would not prescribe that there. If any point, if it's inevitable, the mom's life is in danger, we're in a different ballgame. So the only time I'm talking about referral is in the case of an elective decision. All other decisions we can treat and take care of at the hospital, but in the sense of an elective decision only, we would refer out and help them to Planned Parenthood.
thanks. And Dr. Bonnievie Rogers?
Yes, we don't, the same program is so amazing that we usually refer patients to the ER for any issues.
I think something that's really important when we're talking about sexual assault and sexual violence is that no patient is obligated to report a rape. No patient, any patient who has experienced sexual trauma should not be put in a position where they like have to report and have to take legal action. And so Planned Parenthood, just, we do not have the capacity and the facilities to do rape kits. Should a patient come to us and say they would like to pursue legal action or go along those lines, we can refer them to lots of different services. Or a patient is telling us part of the trauma-informed care that we do is, this is something that is part of my past. I need a prescription for Ella, which is emergency contraception that's effective further out, as opposed to the Plan B that's got a smaller window. Or a patient looking for a referral to a trauma-informed mental health professional. There are a lot of things that we can refer out for. But it is not our responsibility to report things that patients don't want us to report. And so just, taking in every appointment, regardless of what the patient is in for, the patient is in the driver's seat. That is their appointment and their choices. My personal, obviously I'm not in appointments, I'm not a provider, I'm a political nerd, but my opinions and my feelings and what I would do doesn't matter. And that's the same for all of our healthcare providers, that what they would do in that situation doesn't matter. We're here for the patient. Again, similar, we would be referring out for rape kits, but just something to overshadow in this whole conversation.
Thank you. And just as one other bit of follow-up, I think it's really going to be interesting to see the way that the pandemic impacts some of these kinds of issues. There is a statewide behavioral health youth survey that is offered through the school systems that is going to be coming out, I believe, next Tuesday. Preliminarily, at least, it does look like there's been a reduction in a lot of episodes at the high school level, anyway, of witnessed events of sexual violence or rape, and it'll be interesting to see if those numbers really do confirm a drop there. But there was a question from a participant in the Q&A about those numbers, and you may not have the answer to this, Dr. Waldman, but based on the data that was provided by VM, 133 tubules were done in 2017, and then in 2021 that number dropped to 46. Again, it's hard to know the extent to which the pandemic was responsible for that, or other causes, but do you have any idea about what might explain a rather precipitous drop in those procedures?
Yeah, I think that's a hard one, and thanks for asking that, Gib. And maybe Regina, you have an idea also, because we all perform them. I've had no less requests for tubules, and I see that data. It looked a little less when they have the whole year added out. You do see a little drop, and I feel like I have to chalk that up to the pandemic. Nothing has changed within the hospital. You don't need a consult. You don't have to ask the ethics committee. You just plan your tubule and you do your tubule. So I feel as though it was a result of patients' desires. We were all in a tornado and twisting world for the last 2 years, and I think it's just got twisted up in that, honestly.
Yes, that's, I agree with Leslie. That's a really hard, kind of to figure out, because there was a point where a lot of elective procedures had to held back because of COVID. So I don't know if that impacted that level. From our OBGYN, if the patient would like a tubule after delivery, they can facilitate that.
Thank you. And I think we'll ask Betty a question at this point to keep everybody on their toes and awake. Betty, would you let us know what hospice services are available in Kitsap, and whether there are both secular and non-secular options available to patients? And if so, are there any differences between them?
Certainly. There are 4 services that provide hospice in Kitsap County. I'll start with the easiest one, which is Kaiser. And so if you are within the Kaiser system, they have hospice providers, and they also support end-of-life Washington, or end-of-life options. They actually have a phenomenal navigator there, but they only serve Kitsap, or they only serve Kaiser clients. We have CHI Franciscan Hospice, and they also provide good medical care in the hospice setting. There is Providence, which is new to me, and my understanding is that they're serving mostly very much South Kitsap, not so much the rest of the community, but I could certainly be wrong about that. And then there is Multicare, which is secular, and I'm sorry, it's non-Catholic, and it is stretched thin, provides wonderful care with nurses and auxiliary services also, as most of the hospices do. Those are the 4.
Thank you. And there was a question in the Q&A about, do we have any idea how many Kitsap residents have actually terminated their own life through that Death with Dignity Act? I think, the numbers that I saw were statewide about 1,500 in the first 9 or 10 years of that law. Our pro rata allotment of that, based probably on a fairly representative age distribution in Kitsap, would be about 45. But are you aware of any, and can you speak at all to their experiences with that?
Yeah, the state health department does not keep by county records that I could find. I probably deal with 10 clients a year. But what's interesting is that it really goes in waves. So I've had 10 clients at one time, and currently, because of several deaths in the last few weeks, it seems like every Monday I'm assisting with a death, I'm down to 1 client that's active at this point. So it's kind of all over the place. They're all poignant. I was with a man that I've worked with for over a year, a couple Mondays ago, and it was a perfect death. He was ready. He had family around. Family chose to leave, but his longtime sweetheart was there. He took the medication, got it all down very quickly, even though it's very vile tasting. And he died in 20 minutes. So that's, I hope that addresses your question.
Yeah, thank you. And do you know how long it takes to get those medications to the patient? There was a comment in the chat box that that we don't have any pharmacy in Kitsap that provides those. Do you have any information about that?
It's correct. We don't have any pharmacies in Kitsap. So Tacoma and Kent are the pharmacies that we use. They both deliver. They're both very responsive. But in fact, from the date that the first oral request is made, you have to wait 15 days to make the second oral request, then a written request, and then it generally takes 48 hours before the prescription can be sent to the pharmacy, and then it's a couple of days before they can get the medications out. Now, again, the pharmacies have been incredibly responsive, and sometimes it's only hours after they get the prescription, depending on the desires and the condition of the individual client. They may want to take it right this minute. And they might say, I'm only getting the prescription because I want that final piece of control of my life when everything else is going out of control. And so then it'll be either held at the pharmacy or they get it and they hold it at their own homes.
Thank you. And I'd like to roll this question over to our two physicians, just really about advanced care planning and Medicare for probably at least 4 or 5, maybe even more years has covered the cost to providers to counsel their patients as part of annual Medicare wellness visits. Do either of your organizations track the frequency with which your providers are having these discussions with their patients? It's covered, for Medicare, that's 65 and up. Arguably, these are conversations that should start sooner. They're really not exclusively the domain of the primary care provider or of the physician, but also should be part and parcel of just ongoing family discussions beginning at early adulthood. But are these conversations happening between physicians and their patients in Kitsap, in your opinions, or is there any tracking or monitoring of the frequency with which those conversations are happening in clinical settings? Dr. Bonnievie Rogers, I'll have you go first.
I had a feeling it was going to be me. As an internist and seeing the older patient or a more chronic disease, it's an integral part of care. And I think it works quite well with the annual wellness visit. And we've been tracking that more, and it's becoming more important, and having continual training for providers, especially not just MDs, but we have advanced practice clinician, physician assistant, and nurse practitioner who has panels. And I think, we could do better, to be honest, from both training, and I hope Dr. Waldman with her residents doing that a lot, because I think it's a vital aspect of the patient's right to know what they want to do later on in their life. And what I was a little bit touched with COVID is because of that, a lot of elderly patients, unfortunately, could have had a much more dignified, graceful end in their life if they had a plan. And, when COVID just went crazy, they would have been at home and may have passed away better at home than being attached to, being in ICU and so forth. So that really touched me, and I've been really pushing it with my provider team to really address. And it's part of our Medicare annual wellness visit kind of a handout to discuss advanced planning, polls forms, and etc.
I think I would mainly second what you said. I mean, it's such an important conversation and nothing that I want to talk about during a crisis or in a moment of surprised unhealthy changes. What I would say, Gib, to you is we track how many patients have had a Medicare annual wellness visit, but a little bit of silver lining with Virginia Mason is that, the patient-physician relationship is sacred, private, and you can check a box if a patient has had it, but none of us know what happens in the room except the patient and the doctor. So how well it's done and what comes out of that visit is very independent on the patient. And just in my own thing, I mean, as in public knowledge, I'm glad we're talking about this, because I would say even in my younger patients that I bring it up to, it still feels like an elephant in a room and a total surprise conversation. And the more we make it a normal conversation, I think the more it would help all of us in this scenario. But we could give data on Medicare and wellness visits, but I don't think that gives us really good information overall. So, it's an individualized system that we need to constantly be trying to improve.
I'd like to make a comment, which is that on endoflifewashington.org and endoflifewa.org, there are all of these wonderful advanced planning documents. And one of the pieces that's on there is how to talk to your doctor about end-of-life planning. So just know that that's available.
Thank you. And just, I can't overstate how just wonderful it is to have a residency program here in Kitsap, primarily because this is an opportunity to really impact young physicians who are coming out, and we have this golden moment in time to influence the trajectory of their careers, as well as just the recruitment aspect of people who land here and get educated here, enjoy and love the area and want to stay. So primary care is just such a hugely important part of the healthcare system and the public health system. And it does tackle those really upstream areas where we know we can make a huge difference with minimal investment. But I think it's important for people to know how to talk to their doctors. It's also important for doctors to know how to talk to their patients about these. And do either of your organizations have any specific trainings that you give to docs or resources that you use, healthy choices or anything like that with regard to these discussions?
Yeah. So and this is within Virginia Mason. So all of our providers go through a 2-day palliative care academy that's run by Dr. Mimi Patterson, who's amazing. And so our residents do that every year. They have a couple days specifically training in end of life discussions, choices. So I think that's great. But I am impressed that Virginia Mason has every single provider go through that. And that only started a few years ago. So granted, if you've been in the system for a while, you may not have done it, but now everyone spends 2 days with our palliative care team, specifically talking about, we call it a building a house, is what they train us in and how to have the conversation. And it's an awesome 2-day training event.
Well, thank you. And let's see, I'll roll an easy one over to you, Dr. Bonnievie Rogers. Does PCHS accept patients without insurance?
That's what we're here for. Well, as a fairly qualified community health center, we are kind of the safety net for the community. So we take all comers, whether you're high income, Blue Cross, Blue Shield, to no insurance. And so when it's in our website that someone I read at the chat, just ignore that. We'll make an appointment. We never close our panel like some, if there's available appointment for new patients, we will see you. We will welcome you into any PCHS clinics.
And while I'm here, I'm just going to give a plug for PCHS and their innovative approach to really truly wrap around services. I think incorporating behavioral health approaches into the primary care clinics is a huge advance in terms of healthcare. We've just seen throughout this pandemic the just inexhausting inexhaustible and exhausting demand for mental health services. We know how hard it is to achieve those. Really, to be honest with you, members of and clients of PCHS probably have better access to healthcare than a lot of the rest of us do. I think that's really important, as are these novel approaches getting out into the schools, using mobile units, going out to the shelters. So thank you for that. Why don't we ask Dr. Waldman a kind of a specific question? How are ectopic pregnancies managed?
And I might give just focus, if it's okay, and answer the question a little earlier about the doctrine, because I think that might be helpful. And please excuse if I don't use politically correct words, because I'm definitely medically focused with an interest in politics. And so my verbiage might be different. But yes, I think just clarifying. So St. Michael's is non-Catholic. That was part of the agreement when we affiliated from an independent hospital some time ago. So although we are owned by a Catholic institution, the religion doctrine that specifies healthcare does not apply at St. Michael's. And so that's the difference. And that was early on in the agreement with affiliation and is not something that can be changed. We are the only non-Catholic, or again, the most common word that I think people know is secular. That's in place and will stay that way despite us being the only hospital. So that I think changes a lot of these ideas. So for us, an ectopic, if the tube needs to come out, we'll manage it the safest way for the patient, number one, and what the patient desires. But we can use medications, we can use surgery in the instances that we need to. We can take out the tube. I know that there has been some people hearing like, you can't remove the tube. We will remove the tube if that's what's needed for the patient. And so we would do it without any influence of someone else. We would do it in what the best interest of the patient is.
I'm going to slide in because the legal side, that is the Protecting Pregnant Patients Act that was passed last session, so the 2021 session. Regardless of any ethical religious directives, regardless of hospital policy, a hospital that has a patient in their emergency room needing miscarriage management services, needing ectopic pregnancy management services, needs to receive the proper care. There were instances of patients being said, well, you got to go to Seattle, or well, you got to go to Tacoma, and they're in Bellingham, or they're in Kelso, or they're hours and hours away from a hospital that will perform an abortion to save their life. And patients, it is now illegal to do that. So any hospital, regardless of religious affiliation or anything else, has to provide that care. So that is protecting pregnant patients. That is the protection that they have.
Thank you, Alexa. And just I think to follow up that question with one, again, directed to Dr. Waldman, with the shift from Harrison to CHI, have you as a provider really seen any qualitative or specific shift in what you're able to do, or general approaches to either reproductive rights or to late life health issues?
No, and I would say, I joined at the time Harrison for a brief time before it came CHI, Common Spirit, and then Virginia Mason. So I joined them in 2016, having been in the community for a while. I have the lucky pleasure of having another physician in my household who has worked for the company way longer than that, who is also primary care. And so my husband has attested to this a little bit because, yeah, as you can imagine, it should be important to every physician. I have not seen any changes whatsoever. And I know that idea of the non-Catholic and the secular is very important. And it's very important to the physicians who were part of that decision to affiliate with a larger institution for multiple other reasons. So I don't feel that. Again, you can see my years are limited. So I wouldn't want to speak for people that maybe have been in the system way longer than me. My husband has been in the system many years longer than me, and he has not felt a shift. But that, again, is two small opinions. But I don't see that. I don't think our residents feel it at all. Again, we do vasectomies in our clinic. We do everything that we believe we can offer. And so I don't feel that way.
Thank you. And I'll ask Dr. Bonnievie Rogers sort of the corollary question. Have you noticed any limitations that have been placed on the services that PCHS can do through your partnership with respect to hospice, death with dignity, or other reproductive issues?
Not at all. I've not seen any limitations. Because we're mostly primary care, we depend on the greater community and especially CHI for specialty care, whether it's cardiologists or kidney specialists. So I've not seen any limitation in regards to hospice care or any of those issues.
Thank you. Okay, and I think we'll wrap it up with one final question, which just kind of came to me, and I'll ask Alexa this question. Do we have in Kitsap any of these duplicitous organizations that sort of present themselves as abortion services, but are really more configured and designed to steer people towards maintaining pregnancy rather than terminating?
Yep. Yes. These are called crisis pregnancy centers. There is one 3 blocks away from the Planned Parenthood in downtown Bremerton that uses the same font that we do to try to mess with us. So there are a lot of times there's like this weird thing with Google Analytics that you can pay a lot of money to fund to like bump your search results up. So sometimes people will search like pregnancy options and other places will pop up ahead of Planned Parenthood, specifically because anti-choice, anti-abortion groups make a lot of money and use it to fund people to protest outside of clinics and fund crisis pregnancy centers. And the really awful thing about crisis pregnancy centers is that like they'll come in, or you'll come in and you'll say, hey, I want to talk about my options. And they'll say, oh yeah, you can parent this child. You can give this child up for adoption. Come back and we'll talk about all your other options. And they just keep pulling you in and pulling you back and pulling you back to come for other appointments. And then suddenly you're way too far along to have an abortion, even if that's what you wanted to do. It is, it's so just like insidious. Like duplicitous doesn't even begin to cover it, because it's the activist in me is like, how much can you hate women and people who have uteruses? Like really, how much that you need to do this and take away choice? But I mean, we're seeing it all over the country, right? Where I went to college on the East Coast. There was a crisis pregnancy center down the road from where I went to college, which is insane. So it's really just about like continuing to be a loud presence on the peninsula and continuing to be in Bremer to be like, no, we are Planned Parenthood. We do abortion services. We can provide you with all of your options. I mean, we have patients who come in for an abortion appointment and say, actually, I don't want to do this anymore. Okay, here's your resources. Here are other places to go. We're not the abortion factory, you know. There are plenty of other options that people choose. And our motto is care no matter what. So no matter what you choose, we're here to help you make those choices. So maybe we're referring people to Dr. Rogers to say, hey, we can't provide you with OBGYN services here, but there's a clinic down the road that totally can. And let's, you know, while you're referring patients to us who want to have an abortion, and that's what we can do for them. So it's about, again, putting the patient in the driver's seat and giving them what they need, as opposed to these crisis pregnancy centers that just say, here are your options and we have nothing else to tell you.
Well, thank you so much. I really appreciate this conversation. I learned a tremendous amount, and I hope that everybody watching did as well. There are a few unanswered questions still in the Q&A, which Jessica and or Lenny will farm out to our panelists and hopefully get answers back to all of you. I really want to just thank everybody for a wonderful discussion of some really important and timely topics. And again, I look forward to working with all of you going forward. And with that, I will turn it back over to Jessica Guidry. Thank you.
Thank you so much, Dr. Morrow. And I do want to second what Dr. Morrow said. I really appreciate, so thank you to all of our speakers. I know you all are very busy, and these topics that we talked about, I mean, well, they're deeply personal, they can get political. So it's really important for us to have conversations like this. So I really appreciate the time from the presenters. And then also, Dr. Morrow, your time as well, at moderating. Also, Lenny, for doing the tech. Really appreciate, and also for our participants, thank you so much for the questions you asked. And please know that this webinar is being recorded. It will be posted on our website. And then also, as I mentioned at the beginning, we do have a list of resources that we're compiling. And Betty, I was writing down the list of the 4 like hospice providers, so I can add that to the list as well. And that should be posted on our website pretty shortly. So again, thank you all so much for your time. Really appreciate it. And also please feel free to also learn, in that list of resources will also be websites for all of the organizations represented during this call as well. So really appreciate your time. And yeah, I hope you get to enjoy the sunshine today.
Yes, and I'd just like to piggyback on what Jessica said about the resources list. If you registered for this webinar, we have your email address and we will send you a copy of that resource list.
Awesome. Thank you, Lenny. And with that, we want to wish you all a great rest of your day. Thank you.